Okay, and we're live. Hello, it's Bill the Knee Pain Guru, and welcome to the Ask Dr. Beck show. Hello, Charlie.
Good morning, Bill.
How was your Christmas?
Quiet.
Those are good Christmases.
It was nice, yeah. It was very nice.
Excellent. Anything else up in your world? You were mentioning just before we started here that there is people that had unique and special conditions that are seeking you out.
Yes, I'm on vacation, and it's amazing how many people I have to see on vacation.
I hear you. Yeah. Any interesting things that came up in any of those people that were reaching out to you?
No, not really. Nothing that super stands out.
Other than structure governs function.
That's, yep. And
Okay.
tensegrity.
Tensegrity structure. So many things go back to that, and it amazes me how elusive that concept is to the better part of everybody.
Yeah. Yes. Oh, actually, there is something that stands out.
Okay.
And I don't know. This is not me tooting my own horn. This is looking at how what I do is different.
Okay.
So I have people that find me from all over the world.
Mm-hmm.
And I had husband and wife that the wife's family is from Indiana, but they live in Mauritius, which is in the middle of the Indian Ocean.
Okay.
Other side of the globe.
Okay.
And so that's literally where they reside. They come back, and when they're home once a year or whatever, they come in to see me.
Okay.
Well, they've been seeing whatever practitioners there are on the island, and it basically came up, there's nobody that does it like you.
Okay.
And I hear two things. First of all, we're all unique.
Sure.
And secondly, the training that I received somehow made what I do go into my head in a different way than other people and how they are trained. Like, I get different results.
Yeah.
That's all.
That's cool. And you do.
Yeah.
I mean,
Yeah.
I've experienced your work, and it really zeroes in on what's going on. So
Yes.
The one time, I mean, when I drove North Carolina, that was it 8 hours, came to see, and you zeroed in on exactly like trauma, like there was shock that was stuck in the body, and you work with that percussive piece on my heel and completely shifted everything.
Yeah.
For me. So, I mean, it takes a trained person, but then a person that has a skill set that they show up to the training with and then train with. It's just a different animal. I get it.
Yep.
So you're good.
Yeah. Well, apparently.
So that's awesome.
Yep.
And there's a total disconnect between like the middle of the Indian Ocean and Indiana, like, but cool.
Yes.
Okay. Ready to dig into questions for today?
Absolutely.
Okay. We're talking about colonoscopies. Colonoscopy as an assessment tool. Dear Dr. Beck, what is your opinion on colonoscopies as an assessment tool? How often do you think they should occur?
Wow. Well, I will say that
no jokes.
10, 15 years ago, I probably could have answered this because I was closer to doing hospital medicine and understanding more about what the guidelines are. Okay. Mm-hmm. So I will give you my experience, which is 15 years past being in the hospital. Mm-hmm. So the idea behind a colonoscopy is that we use a camera to get a look at a cleaned out colon. And so in order to do a colonoscopy, first you have to have a colon prep, which basically means that we have to invert your bowels and get everything to come out of them. Colon preps are hard. You spend the day on the commode getting everything out. That is used by the person or the people administering the colonoscopy to make sure that they can actually see the walls of the colon. So to put it bluntly, we remove the fecal material. Okay. And then what happens is you get this thing called twilight sleep. They use something called propofol, which is the term in the hospital is milk of amnesia. It's a white milky liquid that makes you not remember what's going on. And they keep you just barely out, the anesthesiologist does. And then the scope goes up your rear end and the doctor drives the scope looking from basically end to beginning of the colon. The idea is that we go through and we actually have a visual so that we know what's going on. And we can see things like diverticulitis, an invagination or an outpouching of the colon. We can see things like polyps, and then there are tools that you can use to go through the scope and remove the polyps. So that's the idea, okay? There are risks that go along with it. The camera in the hands of a skilled operator is pretty safe but I mean, the accidents do happen. Sometimes you get a perforation, the camera goes through the wall of the colon, and that means immediate surgery. So there are risks involved. There are benefits involved. Something that's a polyp that, I don't know, in a few short years could develop into cancer, you can take out, and you can then increase your awareness of what's going on, potentially change your lifestyle and avoid the cancer. Okay, so that's the background. Now, how often? How often seems to be dependent on the person that you ask. When I was doing medical school, it was usually a yearly colonoscopy beginning at around the age of 40, which is roughly when your risk of cancer goes up. Okay. My understanding, and I don't know how well that they work, I haven't looked at the studies in relationship to a colonoscopy, but they make a camera in a capsule. You literally swallow a little bitty camera. It goes all the way through and takes pictures. And then basically you poop out the camera, but before you poop out the camera, there's a way they can look at the pictures. Okay, now, the benefit is no colonoscopy at that point. The detriment is if we find something that would need to be removed like a polyp, well, the only way to get there is colonoscopy.
Right.
So it would potentially lessen the number of colonoscopies that you needed. And if you did need one, they would kind of know where to go and look.
Okay.
And that's a roundabout way of not answering the question, because honestly, I don't know. I have an opinion, but my opinion, it doesn't seem valid because I'm not around hospital medicine anymore.
Got it. And if you could just make a distinction for the audience, hospital medicine and what you do, just.
So there's basically things you do in a hospital, which we consider inpatient. You are admitted to the hospital. Then there is outpatient medicine, something that's attached to a hospital. So let's just say you go into the hospital for whatever your condition is, and you have to come back and see a surgeon, for example, who did your surgery in the hospital. That would be considered attached to the hospital still. And then there are those folks who just do clinical medicine. So all I do is non-hospital medicine in my office. That's it. So some things, knee pain, back pain, those kinds of things, I'm really up on because it's what I see every day. People that have gone to the hospital and for whatever reason didn't get the outcome that they wanted, I see those folks. Occasionally, I will send people to the hospital because they need something that I don't offer, but I don't see patients in a hospital setting anymore.
Got it. Okay. Excellent. For those that are watching, if they would like to send in a question, you can do so in the live chat or the comments section. We did get one here from Kathy, but before we get into Kathy's question, let's do a little promo here. How about that?
Perfect.
Our mission at the Comella Foundation is to relieve pain naturally using osteopathic healing principles. The Comella Foundation is recognized as a nonprofit 501c3 under the Internal Revenue Code. Your contributions are greatly appreciated. Please consider taking a moment and donating to the Comella Foundation to help us continue our important pain relieving work. Every little bit helps.
And we're back. Yes, for those that are watching, donations are greatly appreciated. You can go to the comellafoundation.org/donate, and it's very helpful for us in terms of what we're doing. Let's see. Okay, Kathy's question. Let's dig in there. Kathy writes, good morning. Can thyroid issues, hypothyroidism, be caused by first rib and neck issues? Can osteopathic treatments help?
Love these questions. Yes and yes. Next question.
Come on, you got to make it a little bit more. Make it more dramatic, Charlie. Come on. Okay. This could be a lesson for the people that are watching. Phrase your questions something other than yes or no.
Yes. I'm happy to elaborate, but those questions, yes. First rib and neck issues can be linked to hypothyroidism or thyroid issues. Sure. And can osteopathic treatment help? Absolutely. So we've got to back up and look at thyroid issues and specifically hypo or underactive thyroid. And so first we have to introduce our characters in this game here. T4, which is quattroiodotyrosine. Okay, that's T4. So quattro meaning four. Right. It has 4 iodine molecules on a tyrosine amino acid. Okay. That's T4. Okay. That is our storage form of thyroid. So to me, it's the wood in the wood pile outside your house that will be burned in the stove. Okay. We use an enzyme. I'm going to come back to the enzyme later because the enzyme is important. But we use an enzyme to cleave one iodine molecule off of the tyrosine to make triiodotyrosine, T3. Okay. T3 basically is the wood in your stove. Okay. So if we think about it, we're in winter in North America, and that means that you should have prepared and had firewood outside already ready to go for your stove. Okay. And then when it gets cold, you put wood in the stove. That keeps you warm throughout the winter. Think of the body the same way. The body needs to be able to create T4. In order to create T4, we need the amino acid tyrosine and we need iodine. Where we get iodine is from the ocean, from the sea. So for those folks who live in or around the coast where you get rain that comes from the ocean, that rain will have picked up iodine because as the ocean water evaporates, turns into rain, you get iodine. That iodine goes into the soil. So if you are eating local vegetables, you likely have enough iodine in your diet. Okay. Weather patterns move from west to east in North America, which basically means if you live on the left coast, you're okay. No big deal. If you live inland, where's the iodine come from?
Right.
It doesn't. It's not naturally in the soil in large amounts.
Mm-hmm.
And so for those folks, you need to supplement iodine.
Mm-hmm.
And that gives the basic building blocks for your thyroid to be able to work.
Mm-hmm.
Okay, now I mentioned an enzyme. The enzyme is called 5'-Diodinase. It basically cleaves an iodine off. That's its job. And in order for it to work, it needs the trace minerals, zinc and selenium. So in order to cleave T4 to T3, you must have zinc and selenium in your diet as well.
Mm-hmm.
And so if you've got tyrosine, iodine, zinc, selenium, you basically have the right things for your body to then be able to function normally,
Mm-hmm.
assuming there's nothing interfering with the gland. Okay, well, that's our background. Now, so Kathy's question was first rib and neck issues. So then we have to establish where the thyroid is. The thyroid is in your neck. Okay, so it's in the front, just below your voice box. And the thyroid's gland in the body, in the immune system, is that iodine is a universal killer of bacteria. So we use iodine on the skin, for example, to make the skin sterile so that we can do surgery, so we can cut through the skin and not take bacteria in with us.
Mm-hmm.
The statistic that I read, this was many years ago, is once every 17 minutes, every drop of blood in your body has flowed through the thyroid gland.
Wow.
So it gets exposed to iodine. It's the body's way of keeping down the bad bacteria. Okay.
Mm-hmm.
If you don't have enough of the iodine flowing through the body's pretty wise. It says, hey, the iodine, the thyroid gland concentrates iodine. It's a sieve. Okay. If there's not enough iodine, I have to increase the surface area of my sieve. I've got to be able to filter more iodine out of the blood.
Mm-hmm.
And so you get this thing called a goiter. And a goiter is a swelling in the bottom part of the neck.
Mm-hmm.
We don't see them very often because we use now iodized salt, and there's enough salt. In many cases, there's way too much salt in people's diet. And the salt then has iodine in it. So theoretically, we get enough iodine. It's not always that way with people, but theoretically, we get enough. So if we've got this gland in the neck, and the gland in the neck is supposed to function osteopathically,
Mm-hmm.
that means it should not be inhibited. There should not be abnormal tensions on it. This is where we're going to come back around to tensegrity and structure governs function.
Right.
If I have tension in the neck and, let's see, we'll make up a good one here. Christmas is barely over, so you were taking down Elf on the Shelf. Elf on the Shelf fell, hit you in the neck. Okay, not much, just a little bit more than a tap, but it caused the tissue to get a little tight. Okay, and that's our good story. We'll flow with that because we're in the Christmas season.
Okay.
So that slightly tightened tissue is going to put a traction or a pull on the thyroid. It is going to slightly change the blood flow.
Mm-hmm.
Now, slightly, right? The tissue is not going to die or anything else, and you might not even have pain from it, but the tissue is a little tighter.
Mm-hmm.
Because of that structure governing function, the function of the thyroid will go down. It's not getting the adequate blood flow.
Mm-hmm.
And because of that, you could then develop clinical symptoms.
Mm-hmm.
Okay. So if it's worse, if, let's say, for example, I was going to pick up the top ornaments off of my tree, and I did something and I tweaked my shoulder, which then would influence the first rib. Now we've got even more pull on the thyroid gland. And so, again, more of a deficiency.
Mm-hmm.
And that can be enough where those things alone can contribute to or be the totality of the symptoms of hypothyroidism.
Mm-hmm.
Okay. I have also found a link between the thyroid gland, chronic fatigue or fibromyalgia, and fractures, whether those fractures are true fractures, meaning they would show up on an x-ray, or whether they're forces that have come in slightly slower. So if it would have been faster, it would have fractured. But the physics force is still in the sacrum. And people come in and they tell me about hypothyroidism. They give me a list of symptoms, and I'm thinking, oh, what went on with your sacrum, and do we need to work on that? So absolutely, yes. First rib, neck issues can be linked to hypothyroidism, as can trauma to the sacrum.
Trauma to the sacrum. Huh. Interesting. So we'll get the information on those four. There was zinc, selenium, iodine,
Tyrosine, and iodine. Yep.
Okay. So links. I'll get those in the show notes.
Perfect.
And Kathy continues on. She said, interesting. I live in a beach town in Connecticut. When I have osteopathic manipulations, my thyroid area hurts a couple days later.
Huh.
I first thing that pops into my head is, where are the osteopathic manipulations taking place? Like,
Yep.
like where in the body is being manipulated? And then,
Correct.
That's the first thing that I would.
And then, is it occurring in a sequence that the body can understand?
Are you talking about the osteopath sequencing
Correct.
the manipulations in a way that the body doesn't reject the manipulations?
Yes. Or and reject might be a strong word. So the body can integrate it easily.
There you go. Yeah, I see what you're saying.
And I can put more words to that. So my mentor is Ed Stiles. Ed, one of the people that he learned from was Fred Mitchell Sr., who during his practice was in Chattanooga. And Fred, Ed would go down and spend some time in Fred's office. And what happened was, Fred said, Ed, I've got a patient. I want you to treat the patient. And Fred had taught Ed how he worked. And so Ed did what he thought Fred was doing. They went through and treated the whole patient. And when Ed got done, Fred looked at the patient and he said, well, how do you feel? And the patient said, well, Dr. Mitchell, honestly, I don't feel any different than when I came in. Okay. Now, Ed had just spent 20 or 30 minutes treating the patient. And so they had become really close friends. And Ed looked at Fred and said, well, phooey on what you do. It just doesn't work. And, that was a challenge. And Fred said, well, you did everything right. You just did it in the wrong order. I want you to go back and retreat the patient. I don't want you to change anything. Don't take anything out. Don't add anything. But I want you to do this first, then this, then this, then this, then this. And so Ed went back and retreated the patient, got done the second time. And Fred looks at the patient and says, well, now how do you feel? Well, it feels exactly like it did when you treated me, Dr. Mitchell. And so this light bulb went off in my mentor's mind. And he said, it's not so much that I need to learn what Mitchell does. I need to learn how he thinks about the patient, because that seems to be the most important part. And so there are many osteopaths, and I can't say that they're wrong. I just do it differently. But they treat the patient the same way. You come in, we're always going to start here, then we're going to go here, then we're going to go here, then we're going to go here. And that is their treatment for every patient that walks through the door. That's not the way that I was taught.
Right.
You feel the patient's body in that moment of that day is going to guide you to a place. You treat that place. And then you take your hands off the patient and you've never felt what you're about to feel when you put your hands back on because something's changed in the patient. It takes you to a new place. You treat that. New patient again, it takes you to another new place. And so for me, treating a patient is always about discovery. I never know what I'm going to do patient to patient.
Yeah.
And even if the same patient were to come in, let's just say twice in the same day, the treatment would by no means be the same. And so most of my job, it feels like, is detective work. It's reading the patient's body, understanding how the body is communicating to you, and the body saying, hey, will you please go here and help me here? I need some assistance.
Sure.
And so that is what's different. So when Kathy writes, this is the way that I get treated, the first thing that says to me is, that is not sequencing. If she can remember it well enough that she knows it, it's not sequencing.
Right.
And that may be why she's feeling the change in her thyroid area. Now, it doesn't mean that what that person's doing is wrong. It doesn't mean that we're necessarily going to get different end results. It means that the path along the way is going to be different.
Yeah. How much, and I get the whole piece. I work on my clients, put your hands on them, and it's always different. Oh,
Yep.
Depends. How much is your questioning, your dialogue with your patients involved in that sequencing process?
Your rooster's awake.
Yeah. He does this thing all hours.
Yes. Ours does too. That's the only reason I heard it.
1:30 in the morning, and it's almost like an alarm rooster.
Yep.
Yeah, he does this.
So how much does the questioning come in? Well, in order to answer that question, again, I have to give you some background.
Okay.
So in osteopathy, we learn the osteopathic triune, mind, body, and spirit, and they are all interrelated. What I have found is if the patient keeps their mouth completely shut, so they just come in, sit on the table, for example, and I do my thing. I'm pretty darn good at picking up on the body clues. So aches and pains, tight muscles, that kind of thing. I might be able to pick up on a patient's like intense emotions, anger, sadness, those kinds of things would permeate into my being, and I'd go, oh, well, there's something going on here. If, however, that patient opens their mouth and they speak to me about what's going on, my ability to pick up on their emotional state and their belief system and any challenges that it may be experiencing goes way, way, way up.
Right.
And for me, then that allows me to focus on the key lesion, whatever that happens to be. Could be physical, could be emotional, could be spiritual or belief system. And so in that way, hearing and dialoguing with someone becomes incredibly important. And it doesn't have to be a big dialogue. It can be 4 or 5 sentences. And that can clue me in enough where I then know how to work with that patient for that visit.
Yeah. It's like I've had clients come in and they're like, oh, my knee. And then they start talking. It's like, oh, yeah, and I had 4 back surgeries.
Yeah.
And
we'll get to the, but that's not the big thing.
Yeah. So it's like the little clue that dialogue uncovers things that I think the nervous system suppresses. When for me, there's when I see the nervous system goes into a fight or flight state, there's a disconnect between awareness and what's going on, and it's like they forget about.
Correct.
It's like we're hardwired to forget about this stuff as a mechanism to be able to stay alive.
Absolutely. And it doesn't necessarily come back. So what's interesting is let's pick scenario. Well, Kathy's in Connecticut, and I'm assuming Connecticut's not that far from the ocean, no matter where you are in Connecticut. So let's just say that Kathy goes to the ocean, and as she goes to the ocean, she experiences the relaxation that being around a large body of water can have on you. So her nervous system completely relaxes. Then she's walking along, and unbeknownst to her, there's a sea urchin. She steps on a sea urchin. One of those little spines goes up into her foot. And now what we've got is nervous system on overdrive, screaming, we need to get out of here. This is very, very dangerous.
Mm-hmm.
And so the moment that happens, the physiology of the body shifts, right? Anatomy and physiology are interrelated. So we'll take any toxins from the animal out. This is just about pain.
Mm-hmm.
And so if that pain stays for just a few seconds, let's say, and then somebody really astute takes that spine out and all of a sudden the pain goes away, that was a close call.
Mm-hmm.
But if that pain stays for hours, days, the nervous system basically gets reprogrammed a little bit.
Yeah.
And it takes, from what I've seen, another human being contact with another person to help downregulate that nervous system and get it back to where she was before she had her accident.
Mm-hmm. Yeah. Gotcha. Curious if you have any suggestions for Kathy in terms of how she might work with her osteopath differently, other than finding a different osteopath.
Right.
That might be more beneficial for her in her work with the osteopath. Other than watch this video.
Yeah, watch this video for sure. The thing that makes sense, because we'll say every person in the healthcare field, and I could probably add in very confidently without fail, was trained by someone. And what happens is when you're trained by someone, you pick up whatever they're teaching you, whether that's good, bad, truth for you, or not truth for you.
Mm-hmm.
You pick that up, and then it takes a while to be able to find your own path. And then if you are teaching others, you're doing exactly the same thing. You're teaching others the good and the bad.
Mm-hmm.
The thing that would likely help the most with her osteopath, because you don't want to say what your mentors did was wrong, because it wasn't. It's just what their mentors did. But feedback about, hey, after you treated me, I felt this way. And a couple hours later, I felt this way. And a day later, I felt this way. To me, that helps me, because I'm always looking at ways I can get better, I can improve. And so it would then help me as the operator to tailor the treatment to match you wherever you're at.
Mm-hmm. I got a great story that Evie taught me this.
Yep.
Which is great. So she was 3.
Okay.
And she had these stamps, and she put these stamps all over this big coloring book, this blank page on this coloring book.
Okay.
And I told her I was going to make a map for her from these stamps. And so I had all these stamps, and I did this big, long, elaborate, like treasure map kind of thing. And I did that when she was gone, and she came back, and I was like, hey, baby, look, I made this big, long, elaborate map for you. And she's going around this whole thing. And of course, it started here and ended like right here.
Yes.
And she's like, Dad, you could just go there.
Uh-huh.
Which is exactly what you're saying. If you can go through everything all of your mentors taught you to do that, or you could figure out, well, where's the shortcut?
Exactly. And then does the shortcut work as well or better than what your mentors taught you?
Yep. Yeah. But it's one of those simple things, the profoundness of 3-year-old lesson for me was just like, she just goes, just go here, Dad. I was like, of course.
Yep. Yeah, of course.
So, okay. Well, cool. Anything else you want to add in there? I think we covered a lot of ground today.
We did.
Awesome. Well, have a good New Year.
Thank you, my friend. I'm pretty sure it's going to be New Year what? We slept through that.
Yeah, I hear that. We'll be traveling up to Kentucky and spending a little bit of time up there. I'll give you a ring. I'll see what the timeline looks like when we're up there.
Good.
Awesome. Okay, Charlie. Well, thank you so much. This is Bill Paravano, the knee pain guru, on behalf of Dr. Charlie Beck and the Ask Dr. Beck Show. Have a wonderful day and Happy New Year to you all. Okay.